So, good morning, and I would be discussing some of the neuro-ophthalmological cases which are not very commonly seen in our practice. So, the first case is about a 13-year-old boy who presented to us with a history of double vision for 1 week, and before that, he had a fall from a height of 10 to 12 feet over a very hard surface, and he fell on the left side of the when he fell down, the left side of the head touched the ground first, and after the fall he lost the consciousness for a period of 30 minutes. At the time of fall, he had mild bleeding from the nose and the ear, which we should always ask because it leads us to the localization where the cause of the neuro-ophthalmological abnormality is. So he had a mild bleeding from the nose and the ear, which suggests he must have sustained a basal fracture of the basal skull. And he had vomiting and headache which lasted for 1 week. So when he presented to us, it was 2 weeks after the fall. His visual acuity was normal in both the eye. He had a left esotropia, which you can appreciate from the clinical photograph. The movement in the right eye were full, but the left eye there was restriction and abduction. He was not able to move his eye beyond the primary position. There was a mild ptosis in the left eye, and there was a pupillary asymmetry. The left was smaller than the right one, and in the darkness, this asymmetry and isochoria increased. That suggests there was a sympathetic dysfunction of the pupil also. The fundus was normal both the eye, and the field of confrontation were full. So clinically, it's a case of post-traumatic left six nerve palsy with the Horner syndrome because he had associated ptosis and a meiosis on that eye. The non-contrast CT was done at the time of his presentation to the emergency, which shows a fracture, which you can see from the asterisk, which shows there's a fracture of the greater wing of the sphenoid and was extending to the sphenoid sinus. So it's a middle cranial fossa fracture at the base of the skull. And the contrast MRI surprisingly was normal, or the brain and the orbit was normal. And even the MRI with the contrast, you can appreciate little narrowing of the left cavernous part of the ICA, which they were not very sure, neuroradiologists, what could be the cause of it, but there was a little bit of narrowing of the left cavernous part of the ICA. So if we see the anatomy of that area and correlating with the neuroradiology over here, so this case had a combined six nerve palsy and ipsilateral Horner syndrome, and which was first described by Parkinson, and it's a very important diagnostic sign because it localizes the lesion to the posterior cavernous sinus. Because in the cavernous sinus, in the posterior part, that's the site where the sympathetic fiber, they leave the cavernous part of the ICA and join the sixth nerve for a brief period, and then they go into the first branch of the fifth nerve, like ophthalmic branch of the fifth nerve, and they run into the nasociliary and enter into the orbit. So the occurrence of this sixth nerve palsy with the ipsilateral Horner syndrome, we can explain by the anatomical course of the sympathetic fiber, which was I told you earlier. And these sympathetic fibers, as they encircle the ICA and join the sixth nerve, they anchor the sixth nerve to the cavernous part of the ICA. As you can see in the autopsy of this one of the patients in the cavernous sinus area, how close is the sixth nerve to the cavernous part of the ICA, and that sympathetic connection to the sixth nerve anchors the nerve to the ICA. So whenever there is a fall, so the whole of the intracranial structure, they shift. And during this shift, we always know the main brunt of the injury occurs where the fixed part of a structure and the movable part of the structure's junction is there. So in the cavernous part of the in the posterior cavernous, where the six is anchored to the internal carotid artery, the main injury occurs over there. And first common site of sixth nerve injury after the trauma, we all know, at the pittus apex. And second is the commonest site is this one, the cavernous sinus. And when you have associated Horner, then definitely localizes the lesion localized at the site of injury over there. And usually in the as the because of the it is seen in the autopsy of these cases who had this type of six with the Horner syndrome. The autopsy of these patients, they showed that there were the microscopic hemorrhages in the wall of the ICA, and even the perineural edema and the hemorrhage inside the nerve, because the nutrient blood vessels, they go from the cavernous part of the IC to the sixth nerve, and they are ruptured. So also of the nerve, which results into the palsy of this sixth nerve. But wherever patient had a narrowing of the cavernous part of the ICA, there might be the microscopic hemorrhages would be there, which we cannot see on the imaging. We cannot visualize it on the imaging. Hence, it's very important to follow this patient, because this hemorrhage may lead to the weakening of the ICA, cavernous part of the ICA, which may later on result into the post-traumatic aneurysm of ICA. And as we all know, post-traumatic aneurysm, they are very thin wall and they are a great tendency to the rupture. Hence, if we get a patient of sixth nerve palsy post-traumatically with the Horner, we should keep them patient under follow-up, just to see the later on they may develop into the aneurysm of the cavernous sinus, which is mainly the dissecting aneurysm of the cavernous sinus. The second case is about the false localizing sign in neuro ophthalmology. Localizing signs. The false localizing sign are the one which reflect dysfunction, which is distant and remote to the actual site of the lesion. Awareness of these signs is important to make a proper clinical diagnosis and to ask for the proper site of imaging of these patients. These signs are called false because they do not lead the clinician to the proper site of lesion. We all know sixth cranial palsy, unilateral or bilateral, is a false localizing sign of the increase in intracranial pressure. That doesn't tell us where the lesion must be, which is causing increase in intracranial pressure. Even the same-sided fifth and seventh nerve in the posterior fossa lesion, we all know would be because of the direct involvement, compression, or displacement of the nerve. But sometimes we get the contralateral fifth and seventh nerve palsy in the case of a posterior fossa lesion. And the explanation for this, that is also focalizing. We might think there's a bilateral lesion, but it is not a bilateral lesion. It's because of the distortion or the rotation of the brainstem, which stresses the fifth and the seventh on the opposite side, resulting in their dysfunction. That is very well known. Everybody knows the transtentorial herniation of the uncus, which compresses the ipsilateral third and the same-sided crus cerebri, resulting into the ipsilateral third nerve palsy and the contralateral hemiplegia. Ipsilateral third nerve palsy first causes the pupillary dilatation. We all know the pupillary fiber are present in the peripheral part of the third nerve. And second is the ptosis. And third is the medial rectus involvement. And when we release this supratentorial lesions is operated, the recovery is in the reverse manner. The medial rectus function comes first, then the ptosis improves, and the pupillary paralysis, parasympathetic involvement improves the last one. So sometimes rather than having a contralateral hemiplegia, because of the rotation of the midbrain, the compression occur on the other side of the crus cerebri, which may present as the ipsilateral side, the third nerve, and the ipsilateral side of the hemiplegia, which also confuses us where the localizing, where is the clinically, where would be the lesion should be. So when you get all these type of different combination on clinical examination of a neuro-ophthalmological case, you may think of sometimes it's not a bilateral lesion, it is a false, might be a false localizing sign because of the rotation or displacement of the brainstem, which is causing more symptoms on the opposite side, signs and symptoms of the opposite side. Sometimes the bitemporal hemianopia, which is a very rare presenting false localizing sign of posterior fossa tumor. And why do we get this type of presentation? Then I just discuss it later on. This is the first case. This is a case who was 16-year-old who presented to us because of the gradual decrease in vision for last 4 to 5 months. And the visual loss was so marked that he was not worried about his associated symptoms of headache, vomiting, or mild hearing impairment, and mild imbalance which he had on walking. So he came to us. When we examined, his visual acuity was subnormal. The motility was normal. The pupil was sluggishly reacting both the eye. The fundus shows temporal pallor, both the side, but the rest of the nasal margin was very clear cut. On field examination, what we found is the temporal hemianopia with a central scotoma, which look like, that is the central scotoma associated with the temporal hemianopia, was the cause for his decreased visual acuity because of the compression of the macular fibers. So that localizes the lesion clinically. Definitely the field examination localizes the lesion to the optic chiasma. But he had the associated posterior fossa lesion symptoms, which he could not explain by the chiasmal lesions. When we did the OCT, RNFL, and GCIPL, the RNFL shows the temporal loss, which again suggests the chiasmal compression, but there was a diffuse loss of GCIPL. MRI of the patient showed a very large lesion over the right CP angle, and that lesion was so large that it was causing obstructive hydrocephalus. And because the mass was compressing the fourth ventricle and causing the obstructive hydrocephalus, the pressure was reflected on the lateral ventricles and the third ventricles, which we can appreciate in the coronal imaging that there was a marked dilatation of the lateral and the third ventricle. This is the dilated third ventricle, as we all know by the anatomy of that area, that the optic chiasma lies in the anterior part of the floor of the third ventricle. And in the anterior part of the third ventricle, the floor of the third ventricle, there are the certain recesses. First is the suprachiasmatic recess, another is the infundibular recess. This is the dilatation of the suprachiasmatic recess with the dilatation of the third ventricle, which causes the displacement and compression of the inferior displacement and compression of the optic chiasma over here, which results in bitemporal hemianopia in these cases. And the down layer imaging, you can see how the floor of the third ventricle is dilated, and you can appreciate the chiasma also displaced down and was compressed also. So correlating both the neuroimaging and the neuroanatomy of that site, we can explain the presence of bitemporal hemianopia in the cases of posterior fossa tumor. And it doesn't localize the lesion to the chiasmal area. It's a false localizing sign because patient has also associated features of posterior fossa tumor, like hearing impairment and gaze disturbances, which were not so marked, so he was not giving much attention to it. It was a long-standing compression of the chiasma, which was causing the decrease in the vision and brought the patient to us. And that turned out on the surgery. It was an epidermoid of the posterior fossa, and after the complete excision, the visual acuity improved quite markedly, because all we know the compressive lesion, once you release the compression, there are good chances of improvement of the vision. The field also showed improvement. It was not that marked what is in the visual acuity. The post-operative OCT, GCIPL was the same, but there was a further loss of RNFL. So that's a case of a posterior fossa tumor which was presenting as a chiasmal compression. And as I told you, it was a false localizing sign. It is because of the obstructive hydrocephalus by the mass. Now the third patient is a 62 years old male who was non-diabetic, non-hypertensive. He presented with complaint of sudden decrease in the vision in the left eye, which he had 3 months back. When he showed to a doctor at the time of his visual loss, he was diagnosed as having optic neuritis, and doctor gave him IV methylprednisolone and kept him on the long course of oral steroid, as he didn't show any improvement in the vision. So he was already taking steroid for a period of 2.5 months on the tapering doses. So when he came to us, we examined him. His right visual acuity was normal, but the left, there was a vision was count finger at a meter of 1 feet. Motility was normal. The people showed afferent pupillary defect in the left eye. The fundus in the right was normal disc, as you can see in the photograph, And the lower photograph shows the affected eye, where you can appreciate there was a pallid disc edema. And when the patient's report examined, when he showed first time when he had visual loss, the doctor wrote that he had the pale and the edematous disc. So when we found that it was a pallid disc edema with a certain decrease in the vision in the 62 years old male who was not hypertensive, non-diabetic, it led to us to make a diagnosis of ischemic optic neuropathy. And ischemic optic neuropathy is mainly it's an arthritic type of ischemic optic neuropathy. And keeping all this possibility, like 62-year with a pallid disc edema, so the commonest cause of ischemic arthritic type of ischemic optic neuropathy is in this 62 years is the giant cell arteritis. And we know superficial temporal artery is the commonest artery which is involved by giant cell arteritis. So when we examined that, we found on the affected side, the artery was very prominent. It was hard and it was non-pulsatile, while on the right side, the unaffected side, it was pulsatile and non-tender. It was non-tender on the left eye because the patient was already on the steroid low doses. So we made a clinical diagnosis of arthritic AION. The previous investigation of the patient showed that he had a raised CRP, though the ESR was normal. With the pallid disc edema, with a raised CRP in the age of 62 years old, the doctor, I think, did not make this diagnosis because it is a common misbelief among the physician and the ophthalmologist that giant cell arteritis is a rare condition and it doesn't exist in India. But it's not that. Because of the rarity and sometimes it's misdiagnosed or underdiagnosed, as it happened in our case. So we did the repeat investigation and we sent the blood for inflammatory markers. And then we started the patient on the steroid the same day just to prevent the involvement of the other eye. And even whatever he had a count finger 5 feet, he should not lose that vision. And later on, tapered the dose of oral steroid according to the titer of the inflammatory markers. We did the superficial temporal artery biopsy, which was that is a confirmatory diagnosis for a GCA. Though the patient was on the steroid for such a long time, 2.5 months, we went ahead with the biopsy because previously it's said you should do the biopsy within 2 weeks of presentation because it may altered on steroid treatment. After starting the steroid treatment, you should do the biopsy within 2 weeks of intake. But it is not like that because in the literature it is said the patient is on the steroid, but you have a clinical suspicion of GCA. In spite of that, you can go ahead with the biopsy even though the patient is on the long duration of steroid because the histopathology doesn't change so fast. And that we also seen in our patient who was already on a 2.5 months of steroid course. His biopsy came positive for GCA and it showed a very active inflammation. He was undertreated by steroid because thinking of optic neuritis, he tapered with according to ONTT trial dose. So he's very active and you can see there is a transmural thickening. All the layer of the wall of the arteries are thickened and they are infiltrated with mononuclear cells. And you can appreciate the giant cell as shown by asterisks in the wall of the artery. And the mononuclear cell infiltration with the giant cell infiltration and internal elastic laminar disruption, as you can see in this slide, that suggests this histopathology was positive for giant cell arteritis. Even the literature it is mentioned, the activity or the inflammation in the artery vasculitis remains even positive for a period of 9 months in spite of being on the steroid treatment. So this is a case of arthritic type of AION due to occult GCA. I would say it has occult GCA because this patient didn't have any systemic symptoms of GCA like jaw claudication, focal headache, scalp tenderness, and proximal rigidity. So we make it a diagnosis of the occult GCA. And it's a very well-known entity where the patients of GCA would not have any systemic manifestation, but they would have a raised inflammatory marker, and they have an ophthalmic presentation, like sudden loss of vision because of arthritic type of AION, diplopia, or amaurosis figex, or sometimes their fundus will just show the cotton wool spots, or orbital ischemia. Ocular ischemia would be there. So occult GCI, as I told you what this entity is, and we need to know about it because these are the cases, because they present with the ophthalmic symptoms, they come first to us. So we should not think that these patients, to make a diagnosis of GCA, they should all have a systemic symptoms. Harry has reported the incidence of this occult GCA in 21% of the cases and is a prospective study on 85 biopsy-proven cases of GCA. And so we all know GCA is a systemic inflammatory vasculitis of the medium and the last vessels of unknown etiology, mainly involve elderly age group. As I said, it is supposed to be rare, hence it is underdiagnosed or misdiagnosed in our place, but its early diagnosis is a must, because by treating them, we can prevent irreversible visual loss in the other eye or the progression of the loss in the involved eye. In India, overall 72% cases have been reported from various parts of the country. And when the results of the Indian data was compared with the Western data, it was observed that early age of onset is seen in our population, male predominance. The more ophthalmic complications are seen in our population. So we have to know about this possibility, and we should keep this possibility in our mind when we see our elderly patient ask for ESR and C-reactive protein. And there's a low yield of superficial temporal artery biopsy in Indian cases. So it's important to know about this entity because ophthalmologists are the main one to diagnose this. And as I told you, early treatment, diagnosis and treatment can prevent this dreadful visual loss.